So when patients come in to see me and they've had a problem with an arthritic hip, an end-stage arthritic hip, and the way that patients present with hip pain is really interesting. When I see patients in the office and they come in with a hip problem, patients will point to all sorts of different areas when they tell me their hip hurts. Classically, hip pain presents as pain across the groin, but patients will point to their buttock, the side of the hip, the thigh, the knee, the lower leg, the back. All these places are areas that patients describe and point to when they come in to see me with a hip problem, if you will. So we manage these issues non-operatively with weight modification, activity modification, avoiding the running, jumping, impact activities. Medications, over-the-counter medications can be very helpful to control pain. A cane or walking stick will decrease the stress across the joint by quite a significant amount. Sometimes injections to an arthritic hip can be helpful, such as a cortisone shot. But in my experience, shots for the hip joint are not as predictable as shots for the knee or the shoulder. So when they reach that point where these things are no longer providing the relief that they're desiring, then what we have left to talk about is a hip replacement. What's involved with a hip replacement? Patients come into the hospital the day of surgery. Surgery takes about 2 hours. 99% of my patients, I do an anterior approach for my patients. They're up walking the day of surgery. We'll have them start walking with a walker or crutches for balance. And then as their strength, comfort, and confidence allows, they can transition to a cane and off of a cane. Everybody heals differently. That process of getting to and off of these supports generally occurs over 2 to 6 weeks, but everybody's different. Patients go home from the hospital when they're comfortable and safe. We have patients go home the day of surgery. The majority of our patients will go home the day after surgery. Some of our patients might be in the hospital a little bit longer, depending upon their support at home and their overall general health. Once patients go home, there's not a lot of physical therapy with a hip replacement. It's very different from knee surgery or knee replacement, and the best therapy that one can really do following a hip replacement is just walk. Driving a car after surgery, I believe, is a patient decision, not necessarily a medical decision. So I think it's reasonable for patients to consider driving when they can use a cane and when they're not requiring narcotic pain medicine during the day. So I think when they're using a cane, they have good control of the leg, and when they're not, of course, requiring narcotic pain medicine during the day. Patients then typically come back to see me in the office about a month after surgery, roughly. At that point, most patients are walking well indoors without the need of a cane or supports, but out of doors, longer distances, they may still be a little more comfortable or confident with a cane. So things these days, recovery following a hip replacement typically occurs quickly over the first few weeks or month or two, but then more gradually for a year. So full recovery is a year-long process, but again, things do improve quickly over the first few weeks or month or two. And of course, the reason we do a hip replacement is for pain relief, primarily. But when I'm talking to patients, I emphasize to them that it's not going to be the hip typically that you had when you were 30. So some patients may always have a little stiffness in the groin, a little tightness in the groin, maybe a little achiness in the thigh. With a scar on the front from an anterior incision, sometimes patients get some numbness or tingling on the side of the thigh, and with scars, sometimes some burning early on from the incision. But those skin feelings, they tend to improve over the course of time. But there may be areas that are always a little different to the touch. Activities that are reasonable for patients to do once they've recovered: walking, swimming, gardening, golfing, mild hiking, using an elliptical machine, walking on a treadmill. Those are all fine things for patients to do from an activity standpoint. Where we live in northern New England, a lot of people ski. And what I mention to patients about skiing is if someone is a lifelong very good skier, I think it's reasonable for them to ski, but for the enjoyment, not the thrill. So greens and blues, less crowded slopes, well-groomed conditions, things can happen. And so if someone hasn't skied for a long time or was never a very good skier, then I discourage them from skiing. Things that they should not do are running, jumping, impact activities for exercise, running for distance, or open field sporting activities. They'll just destroy the materials.